All right, everybody, thank you for joining. Welcome to our last academic half day for this year. The first lecture today is by Dr. Alvaro Vargas, who's going to be talking about hyperlipidemia. So whenever you're ready, Dr. Vargas.
Okay, thank you so much, everybody, for the invitation. Congratulations to making it to the last academic half day. I'm honored to be part of it. So we'll get started. So I don't have any disclosures. You guys can hear me okay, right? Sorry, I keep asking. I just want to make sure.
We can hear you, but it's just a little soft. So if there's a mic, if you could just reposition it.
Mic.
If not, it's audible, but it's just a little on the soft side.
Got it. Okay, I'll try to speak loud, and if you guys have trouble hearing me, let me know. I can use my cell phone for the speaker. Let me try that quickly and see how that works. Okay, is this better?
Yeah, much better.
Sorry, guys, I almost threw this computer on the floor somehow. Okay. Okay, so you guys can hear me okay now and see the screen?
Yeah, perfect.
Okay, sounds good. So we'll get started. So again, I don't have any disclosures except that, you know, I'm not a lipidologist. I'm a second-year fellow. This is kind of like a complicated topic in terms, I mean, it sounds pretty basic, but it gets pretty hairy pretty quick. So I try to do some practical approach to hyperlipidemia. We'll see how that goes. Oh no, what happened here? Okay, so this is the overview. So we'll go briefly about what's hyperlipidemia, why do we care about lipids in general. We'll do a very brief review on lipid physiology. The bulk of the talk is going to be on hyperlipidemia and primary prevention, which I think that what is really what we care about, hyperlipidemia and secondary prevention. And then we'll do hypertriglyceridemia management briefly. But again, most of it is going to be hyperlipidemia and primary prevention. We'll have some questions and case-based type of thing, but we'll get through the intro part first. Most of my sources are the cholesterol and prevention guidelines, US guidelines. When I don't use that, I use some papers which I will tell you which they are. And I also make a quick reference to European guidelines. So we'll start with the hyperlipidemia. Obviously, the first thing we need to do is define it. So there's really not a great definition I could find in textbooks and guidelines, honestly. But you know, obviously, any disorder that in which you have elevated lipids within the body. So what does that mean? You know, some authors have described that as higher than 90th percentile of high lipids compared to the general population. And I'll tell you why that's a problematic definition, but that's kind of what we have. Another more general definition is elevated non-HDL-C levels. So VHDL and LDL, and I will remind you what those particles are. And then, you know, some other, like the American Heart Association, kind of like on the information page, has something among these lines, says that optimal cholesterol is about 150 milligrams per deciliter total, and LDL cholesterol is about 100 milligrams per deciliter. That's kind of like the ideal level. More than 200 or more than 130, that's considered high. So by definition, hyperlipidemia. So those are kind of some of the numbers we've been using in the US in the recent years. Again, what do we care about this topic? A lot of people have it. But most important than like how many people have high lipids, and the point I'm trying to make this whole talk is going to be that what happens after you have high lipids and the diseases that you get. So this statistic, I think, is pretty salient. So globally in 2020, there was 4.5 million deaths that were attributable to high levels of LDL, which is a 20% increase from 2010. So that's kind of like the problem, and that's what we're trying to do to solve it and learning about it. So, I just wanted to give you a sense, when you go back to these numbers and we said that normal cholesterol is below 150 and LDL cholesterol less than 100, just to give you a sense, that's probably too high. This is a graph from kind of like an old study, very interesting. And it shows that, adult Americans, the very last, or like modern humans, cholesterol is about in the 200s range. This is total cholesterol. If you see a lot of other mammals, total cholesterol is a lot lower than that, closer to like the 100. And even some hunter-gathering human communities, the cholesterol is closer to other mammals. So it probably tells you that the cholesterol that we consider, quote, normal is probably too high. And the cholesterol that humans have is way too high compared to other mammals. And that might probably explains why we suffer from so many atherosclerotic disease. There is also something that sometimes comes up is the idea that, you need some cholesterol to function, which is probably true, but it's a lot lower than what we think. This is a study with 200 newborns. If you look at the LDL in the newborns, it's around 50. That's kind of like the mean. And that's perfectly okay for fetal development and newborn development, and why not? This is a study with the PCSK9 inhibitors. So you look at the placebo, this is LDL in the 90s. When you use a PCSK9, it goes down to the 30s and people do completely fine. There is no side effects, there is no problem. So as far as we know, the lower the better. There is not such a thing as too low cholesterol. So those are 2 points I wanted to make early. So we'll go briefly into lipid physiology. Again, this is not a basic science lecture. I just wanted to point your attention to these two particles, the VLDL and LDL. So that has to do with the density of the lipoprotein. So LDL we're all very familiar with, probably the most infamous lipoprotein there is, and the one we have more tools to lower. VLDL is also atherogenic, and we know that, but it kind of goes with LDL, but we don't look at it as much, but it kind of is there. This is just like a cartoon of the different particles. We have the very low density lipoprotein, low density lipoprotein. HDL is high density and is thought to be protective. We also look at it, again, there is no therapies for HDL, but we know the higher the better in that sense. Again, this is kind of like the cycle of cholesterol. I'm not gonna go through it, but basically, you eat foods, you make chylomicrons, you go to the liver, LDL makes VLDL, and then from that makes LDL, and that's what causes oxidation and atherogenesis. And HDL functions kind of like a reverse pathway. We kind of collects that cholesterol, brings it back to the liver, but that's kind of like the big picture. So again, what I really want you to think about lipids, I want you to think about atherosclerosis, because really that's the reason we care about lipids, that and one other exception where I'll go through the end. And when you think about primary prevention and lipids, I borrowed this analogy from one of the Morningside attendees, Dr. Amir, and he talks about primary prevention as the horse is in the barn. And I added that we think it's in the barn, and I'll kind of try to explain what I mean by that. But in this case, we're trying to treat high lipids, which I try to define for you. And we're trying to prevent the first episode or the first clinical event of atherosclerosis. So this is the first case. See if you guys can log into this poll everywhere thing. I would love that to work. But so I'll give it maybe like a minute or so for people to either go to the website or text the code. The activity should be active. See if I can. let me know if anybody is successful logging in and seeing the question and being able to answer. It's all anonymous, so nobody, I don't know, nobody knows who answers what. Okay, good. I wonder if I can know how many people responded. Okay, so it looks like most people answer lifestyle modifications only. Some people answer lifestyle modifications and low molar intensive statin. So let's go through this. So again, 35-year-old girl, obesity, presenting for routine physical. These are the cholesterol. Total cholesterol is high, LDL is high, blood pressure is okay, 10-year ACVD risk is 3.5%, lifetime risk is 40%. I kind of added that lifetime risk as a red herring there for you to try to make the question a little more difficult. So the answer here is lifestyle modifications only. This is based on the primary prevention guidelines from 2019. The main reason for that is that the age of the patient is only 35 years old. So technically it doesn't really add into you know, the ACVD calculator risk for using statins or not. Again, this is kind of like from the guidelines themselves. So, you know, it is useful to estimate the ACVD risk. So you tell the patient there is a 40% chance you're going to have some sort of event in your lifetime. I think that's useful information for the patient to have. If the patient has a strong family history of early atherosclerosis, or the LDL is greater than 160, then you can think about starting a statin. Again, this patient specifically doesn't meet any of those criteria. So the answer in this question is lifestyle modification only. Again, this is kind of what the guidelines say. I think like cardiologists in general, you will learn that we tend to be a lot more aggressive with lipids because it doesn't make too much sense to wait a lot longer. If this person is 35 and already has high risk, if the patient is concerned about it, has a family history or anything else, it wouldn't be wrong to start statin, I think. And I think most people agree with that, but just based on the guidelines, you don't start using this ACVD calculator until patients are 40 years old. Just to make that point, I wanted to share this graph with you. This is from European Heart Journal. And basically what this shows is that, you know, the longer you're exposed to high levels of cholesterol is the worse. So it's not kind of like, it's more like over time kind of area under the curve type situation. So let's start with the most extreme example, which is a familial hypercholesterolemia. And, you know, the threshold, this yellow line here is the threshold where some kind of clinical event occurs. In the familial hypercholesterolemia, because the cholesterol is so high to be, this is minimal, so, you know, it's not the same units we use, but the concept is that the higher your cholesterol for the longest time, then the quicker you will develop the event. And then, so the idea is that, you know, if you have this 35-year-old who, you know, you have somebody whose risk, like this guy who's 35 years old and has very high cholesterol, if you start a statin, then you will move that curve towards the right. And you will kind of like delay the cardiovascular event over time. And that's kind of what we're trying to do. Obviously the highest and the longest time, then the highest the risk. But there is this idea or concept that at some point you'll develop the disease. The question is kind of when. So we'll do another case. This is 55-year-old woman, history of HIV, hypertension, former smoker, family history of early CAD, presents for routine follow-up. These are her numbers. I think it's probably easier for you guys to see it here. Okay. Okay, we'll give it like another 30 seconds or a minute or so for you guys to respond. Okay, we'll give it like 10 more seconds. Okay, so most people said lifestyle modifications and consider low intensity statin. Some people said lifestyle modification and consider more intensity statin. So yeah, those are the answer choices. So in this case, this patient, this again, the 2019 primary prevention guidelines. So patients 40 to 75-year-old with an ACVD risk of 5 to less than 7.5%, they're considered borderline risk. In this case, there is a 2B recommendation to obtain risk enhancement variables, I guess. And then you discuss the idea of starting a more intensity study. So I guess in this case, the answer was B. I use the word consider to talk about these risk enhancers. And this is something new that the guidelines come up compared to the prior guidelines. This risk, the concept of risk enhancers. So what are those? So risk enhancing factors, there is a bunch of them. So there is family history of premature ACVD. And if I'm not wrong, that's less than 55 in men and less than 65 in women, but look it up. I'm not 100% sure. I'm sure it's 50 or 55 in men, but I think it's 55 in men and 65 in women. Persistently elevated LDL greater than 160, CKD, metabolic syndrome. Some of these conditions specific to women, such as preeclampsia, premature menopause, inflammatory diseases, South Asian ancestry, which is something we anecdotally seen a lot, and it's, now we have in the guidelines. Persistently elevated triglycerides, which is something I'm going to talk about at the end of the lecture a bit. And then some of the things you could do potentially in your clinic is measure a high sensitivity CRP, LP little a, ApoB, or get ABIs. So again, just to review, this is for patients who are considered borderline risk, so 5 to 7.4%. You don't really know which direction to go. Then you can look at this list of risk enhancers. You can even measure, order more labs, and discuss with the patient, and and then consider starting a more intensity study. And the reason I think this is important is because gender and age are kind of like the two variables that play the biggest factors in the calculator for ACVD risk. So as you can see, a 69-year-old female and a 54-year-old male, that's kind of what it takes for a woman to qualify for. It's the same labs we use in the question, but a 54-year-old man kind of reaches that threshold of about 7.5%, but that woman will need to be 69 to get to kind of like a similar level of risk. So that's why we use these risk enhancements, which are not in the calculator itself, but that help us identify people who are at higher risk. So we'll do case 3. This is a 62-year-old woman, lupus, CKD, hypertension, obesity. Younger sister had a large MI. She's reluctant, hesitant to start new medications. These are her labs. Again, I try to make it easy in the terms like didn't really change the lipid levels that much. I just changed the clinical history. Her 10-year ACVD risk is 9.2%. We'll give it a minute or so. Okay, so it looks like more people chose lifestyle modification and high intensity statin. Some people answer lifestyle modification and moderate intensity statin. Again, these questions I made up, so they're not perfect. But the point I'm trying to make here actually is that I guess I tried to say that she wasn't willing to start medications right away, which is a problem we see in clinic often. So the answer here is actually calcium score. So we'll go through that. So for people who are between 7.5% and 20%, those people are considered intermediate risk. So in this case, there is a class-wide recommendation to do further like risk assessment. And if or like do the risk enhancers, if that favors statin, then you can do, moderate intensity statin. In this case, with the goal to reduce LDL by 30 to 49%. So we talked about the risk enhancements already. So definitely she has some of those. She has early CAD with her sister. She has inflammatory conditions. So we already know I wouldn't even call her intermediate risk. Like even though the calculator calls her intermediate risk, you already know this patient is high risk. But it doesn't matter what you think she is. What matters is that it doesn't sound like she's willing to start a medication right away. So in these cases, the guidelines, in this, not specifically for patients who don't want to take the medication, but in this quote intermediate risk patients, we can do a coronary artery calcium score, and that will help you to further risk stratify these patients. So a calcium score of 0, and I have some slides on the calcium score. Calcium score of 0, consider no statin unless diabetes, family history of premature CAD, which she does, or cigarette smoking. Coronary calcium score intermediate, which is 1 to 99, favors statin, especially after age 55. Coronary calcium score greater than 100 or greater than 75th percentile, then statin therapy is indicated. Of note, I guess we're not talking about aspirin here, but it's kind of like in the realm of primary prevention. Coronary score calcium of 100 or higher has been one of those things that favors aspirin from primary prevention. I'm sure a lot of your patients have been asking about that since what's in the news recently, and why not? So a little bit of coronary calcium score. So a coronary calcium score you get for a non-contrasted chest CT is specifically ordered and done for that. It needs to be gated, which means you have to know what the systole and diastole is. So like it's not easy to do like on a different, like if you're doing a CT chest for another reason, they won't be able to give you an actual number unless you order an actual calcium score. It looks for calcified plaque, and I bold and underline that because no calcified plaque doesn't mean no plaque. You can also have soft plaque that it doesn't have any calcium, but any calcium you see in the coronary arteries implies plaque. So that sounded a little confusing, but if you see calcium in the arteries, then there is plaque. But if you don't see calcium in the arteries, that doesn't mean no plaque. Hopefully that's better. Is not covered by insurance, which is unfortunate, but it's not that expensive of test. It's $100 to $150. I guess it depends for, which patient we're talking about, but it does give us a lot of information. And then there is this calculator. If you Google MESA CAC calculator, then you can use the calculator, your regular ACVD calculator, and add the calcium score. So I did that for this patient, and I gave her different calcium scores. So I gave her a calcium score of 0, of 100, and 500. So in this case, with a calcium score of 0, her risk goes down to 3%, 10-year risk. If a calcium score of 100, the 10-year risk goes up to 10%. And a current calcium score of 500, then her risk goes up to 15%. So again, it kind of like, for these intermediate risk patients, you can bring their risk low enough so you're comfortable not treating them with a statin, or it can put you up in the sense that you will really strongly advise them to start a statin, and you can, be a little more, maybe paternalistic or try harder to persuade them to start taking a medication, and they can already say the process of atherosclerosis has started, and they might be more agreeable after that. So keep moving on. Case 4. This is 76-year-old man, hypertension, a smoker, presents for routine appointment. Lipids are the same, blood pressure is not too bad. 10-year ACVD score is 44%. We'll give it a minute or so. Okay, so it looks like most of you want to give him some lifestyle modification and start a high intensity statin. Some of you don't want to do anything because he's out of the range, or like do lifestyle modifications only. And then some of you also want to get a calcium score on top of the statin. So this is, try a little bit of a trick question. I guess the point is we all think about these things, not get it right or wrong. So in this case, the answer technically is nothing, right? Because you do a clinical assessment and you discuss the risk of the patient and you kind of go from there, because really the range is similar to the first question when I show you a young patient, it says 40 to 75%. So, if this patient was a year younger, then the guidelines will have a class 1 recommendation to start a high intensity statin to reduce the LDL for more than 50%. But being 76, then the guideline says that you do clinical assessment and risk discussion. Honestly, really, whatever that means to you and to the patient. Again, I'm trying to give you kind of like the exam answers, but I also want to give you the real answer. In my mind, I think in most people's minds, that doesn't make any sense, because 75 to 76, this patient is very high risk, and having a heart attack at any age is not good. I think that's what, at least that's the way we're trained as cardiologists. So, if this patient comes to my clinic, I will definitely give him or offer at least a high intensity statin. Doesn't mean you have to start with like Lipitor 80. You can start slow, you can start at 10, you can start at 20, see how he does, how he tolerates. Oh man, this computer screen. Sorry guys. And then kind of go from there after that. But so I guess the point I'm trying to make here is that there is very specific cutoffs in the guidelines that they might ask you on board exams or questions or whatever, but they're artificial, they're arbitrary, and you have to use clinical judgment and do kind of what you think makes more sense. And I think, a 76-year-old who smokes and has hyperlipidemia should be on a statin. I don't think there's much to think about that. Okay, we'll do one more. I think we have a few more actually. So this is a 59-year-old woman. She has diabetes, but no medical problems. She exercises regularly and has a diet rich in fiber, fruits, and vegetables. Her lipids are actually pretty good. Total cholesterol is 150. HDL is at 80. Triglyceride is 111. 10-year risk is 1.7%. Okay, great. It looks like, okay, one more answer came in. So kind of split here a little bit between reassure the patient and encourage her to continue her current habits. Or half wants to give people more intensity statin, and some other wants to do a calcium score or other risk enhancement. So again, the way I'm wording the question is based on current US guidelines. It doesn't mean whatever else you chose is right or wrong. But this is what kind of like what the guidelines will tell you you need to do. So in this case, the patient has diabetes and she's between this age. So there is a class 1 indication for more intensive statin, regardless of her ACVD calculated risk. There is a 2A for consider a high intensity statin. So the answer to the question based on the current US guidelines is at least a moderate intensity statin, and then consider high intensity statin. And just because she has diabetes. I thought I had another slide on this, but I guess the point is that diabetes is such an overwhelming risk factor that regardless of anything else, the chances of she developing some sort of atherosclerotic disease is high enough that warrants a statin. In these patients, what we end up doing a lot, like in real life, in the real world, coronary calcium score, I think will be a great option for her, because even though she has diabetes, if she has a coronary calcium score of 0, then, really, does she really need to be on a statin? Especially with her habits and her lipids, and why not? But again, this is kind of what the guidelines recommend. Case 6, I think this is the last one for primary prevention. So this is a 35-year-old man. He has a history of premature CAD. His father, who presents for an annual physical. He's a non-smoker. He plays tennis often. I don't know if you guys watching the Roland Garros. And then these are your options. His lipids, LDL is 220, HDL is 45, blood pressure is okay. So based on current guidelines, how would you treat this patient? Okay, so I think most of you want to calculate his 10-year ACVD risk and assess for familial hypercholesterolemia. And then some of you want to assess him for familial hypercholesterolemia, and others want to start a high intensity statin. So let's see what the answer is. So in this case, because his LDL is greater than 190, then you don't really need to do any risk assessment, and you initiate high intensity statin. The idea is that basically the only way you will have an LDL greater than 190 is if you do have familial hypercholesterolemia, which is kind of supported by the vignette where it says that he has premature CAD. So in this case, the age cutoff changes. I don't know if I have a slide with that. No, sorry. So I think it's just greater than, it's just like adults, I think. I think pediatric populations are not included, but like if you're 18 or 20 or something, and you have LDL greater than 190, then you're done, and you treat with high intensity statin with a goal to reduce LDL at least less than 150, kind of assuming they have familial hypercholesterolemia. We don't talk about FH too much. I'm not gonna go into the details. I would like to learn more myself about it, but we know it's a genetic disorder. We know it's very common. It's 1 in 200 to 500 people. And one way you can try to diagnose it or get a sense of it is called the Dutch criteria. And I kind of copy pasted the table here for you. And the nice thing about it is once you add all these things, then it gives you a score, and then it's either unlikely, possible, probable, definite diagnosis of FH. And this doesn't have any genetic sample or anything else. So it's all clinical stuff, which is nice. This is probably the most common criteria used. Okay, so it's 12:40. So that's kind of like the bulk of the talk. Hopefully you guys feel comfortable with the primary prevention stuff. Take a look at the primary prevention guidelines next time and you see the whole chart. But we basically went through everything one by one with the cases. So I'm gonna talk briefly on hyperlipidemia and secondary prevention. So again, this is when a patient has some sort of event, either a heart attack, a stroke, limb ischemia, whatever, and then you're trying to prevent a second one. So you can think of this as the horse has already left the barn. So we'll do this case. Oh man, this computer. Okay, let's try this one. It's 52-year-old woman, aortic stenosis, status post-valve replacement, and STEMI PCI to the LAD 6 months ago. A strong family history. She's on atorvastatin 80. Her pre-treatment LDL was 140. Then clinics today, LDL is 85. What do you want to do? You want to continue the high-intensity statin. You want to add the ezetimibe. You're going to add a PCSK9 inhibitor. Okay, so most of you want to continue the high intensity statin, which is on maxed on Lipitor 80, and then a quarter of you wants to add ezetimibe. Look at the answer. So in this case, this woman is considered, I don't know if actually, I mean, she has an event. There's these two categories, high risk, very high risk. I kind of copy pasted a very high risk here, so I assume it's this one. But basically, she's on a high intensity or maximal statin, which she is. But then what do you do after? So if on maximal statin and the LDL is greater than 70, then adding ezetimibe is reasonable. So that's technically the answer of the question. Then if PCSK9 is considered, so if you're thinking about PCSK, I guess the point the guidelines are trying to make is that the goal for anybody who's had a cardiovascular event is 70, and I'll show you why in a minute. So if somebody already had an event, you need to bring the cholesterol down to 70 any way you can, ideally with a statin. If you're gonna add a non-statin medication, then ezetimibe is the first choice because it's cheap and easy. And if you cannot get it down to 70, then you will kind of reach out for the PCSK9 inhibitors or anything else. Now we have a few more options actually, but that's kind of like the answer. These are the cholesterol guidelines. So here they distinguish between patients with history of ACVD and those with a history of ACVD and very high risk. So people in very high risk, actually it's not very hard to get them to very high risk, are those with more than one event, so like 2 events or more, or they have multiple high risk conditions, which, you know, greater than 65, diabetes, hypertension, blah, blah, blah. So you get 2 of any of these and 1 event, you're technically very high risk and you kind of fall in this, you know, side of the guidelines. So again, bring the cholesterol down below 70 after 1 event and any of these things. See, these are the patients that are not very high risk. So again, these ones, the idea is to bring the cholesterol, LDL cholesterol to at least 50% with the statin. If it's still above 70, then you can do it, but the strength of the recommendation is not as good. You know, these yellow ones are 2As, these orange ones are 2B. So you can still do it, but you know, if you're very high risk, the indication is stronger. And this is if you're less than 75, you're greater than 75, then, you know, it's kind of like weaker recommendation to start a statin, but definitely indication to statin. And I want you to remember when we did the 76-year-old man with no ACVD, that patient, they didn't even recommend the statin to begin with, but for secondary prevention, obviously, you know, there is a recommendation for that. I want to point out these are Europeans. This is the 2021 guidelines. Actually, their target for this patient is 55. So, you know, we're getting more aggressive as we go because we know the lower the better, and there is no such a thing as too low. So yeah, I wouldn't be surprised if the American guidelines also adopt a 55 cutoff for these very high risk patients in the next version of the guidelines. So I wanted to touch briefly on this idea of 1.5 prevention, which is something I heard at ACC this year, and I heard of the term, but it kind of makes a lot of sense. So this idea of subclinical atherosclerosis, you can think of this as the horse is about or might leave the barn. I don't know if this slide in the wrong order. We'll see. Okay, I think this is my last case. Let's do this case together, see what happens. A 50-year-old woman, no prior medical history, no premature CAD, recent ED visit for acute pleuritic chest pain, had a CTA, we show no PE, but they read moderate coronary calcifications, the pain self-resolved, her calculated SCVD risk is 2.1. So long story short, she had a CT chest for whatever reason, and they saw calcium in the coronaries. They call it moderate. We don't have a calcium score per se because the study wasn't done for that. So their calculated SCVD risk is low. So what do you do with that? So it looks like most people want to do aggressive lifestyle modifications and statin therapy. Some people want to get an actual coronary score to help guide therapy. Some people want to do lifestyle modifications only first. Okay, so again, some people want to do a stress test. I'm glad about this one too. So again, all these, I think all these things will be reasonable to do. I don't have, unfortunately, this is not a question that has like a clear answer. As far as I know, there is no clear recommendations for this. But what we do know is that atherosclerosis has started. So I don't think we should treat this as primary prevention, right? Because in primary prevention, there is no disease, right? This is also not secondary prevention because she hasn't had an event, but it's kind of in between. So this is like the prevention 1.5 situation where the horse might or is about to leave the barn. So what do you do? We also know that about 50% of people, the first symptom or sign of atherosclerosis is an event. So her first symptom might not be chest pain. Actually, most people, more than 50% of people, the first symptom is a heart attack. So you don't really want to wait for that. And we also know that atherosclerosis progression slows down, stops, regresses below LDL of 70. I think I have a graph for you. So this is from intravascular ultrasound data and from coronary angiogram data. This is LDL levels here. This is the change in the atheroma. Once you cross below 80, 70, there is basically regression of the plaque. So that's why we are so obsessed with this 70 number, because we've shown that once you get below 70, plaque doesn't get worse. If anything, it gets better. It remodels, it stabilizes, it gets smaller over time. So that's why, you know, if she was my mom, I would try to get her LDL down to at least 70. So whatever plaque she has there is not going to get worse. It might get better. You know, you can also make an argument for a stress test in the sense that you can see if she's any evidence of ischemia. Doesn't mean you have to cath her after the stress test, but if she has severe ischemia everywhere, then you might want to start a beta blocker or something like that. So it's a complicated situation, but we bring it up. Okay, and finally, the last section, again, I'll go through this. My time is up, but I'll go through this very quickly. So hypertriglyceridemia. So basically there's two goals. One of them is prevent atherosclerotic events, and two is prevent pancreatitis. We all have heard this many times. So triglycerides greater than 150 is kind of like the cutoff. Persistent high triglycerides is triglycerides that are greater than 150 or more than 175 non-fasting after 4 to 12 weeks of lifestyle modification. I was hoping to go through this. I don't have the time, but there is a lot of trials that show that omega-3 fatty acids have shown to be beneficial in prevention. But I want to show you the actual recommendation. So let me show you this one is the one I want you guys to remember. So this group, people with primary prevention group greater than 40, diabetes, with high triglycerides, there is now an indication for icosapentaryl ethyl, which is Visipa. And this is something else you can add to your primary prevention patients to try to reduce the risk further of an event. And the other one I want you to remember is the pancreatitis one. So if your triglyceride is greater than 500, or definitely if greater than 1,000, then you wanna treat the triglycerides as well. But with the hope to prevent pancreatitis, but not necessarily ASCVD. Okay, 151.
Yeah. Thank you so much, Dr. Vargas. Any questions from anybody?